Ruth Urashkian, a neuropsychologist, and Carol Janicki is a clinical psychologist. Thank you for teaching us this morning.
Good morning.
Good morning.
So we're going to try to cover 9 questions that are presented to us. We'll have about 5 minutes per question. At the end of our response to each of the questions, we'll ask if you have questions. So raise your hand if you are under 50. Okay. For those of us that did not raise our hands.
In spirit?
I'm going to discuss the differences between normal aging and dementia. Normal aging, do you ever have the sense you can't come out with the word you want to use? Normal, that's normal, okay? Normal aging, you might have slightly slower learning rate, but with time you can recall what you've learned. In a dementia, you have a rapid rate of initial forgetting. So if you learn a list of words, we'll just come up with the list: chair, carpet, cup, ceiling. Okay, the list is usually longer. For someone with normal aging, after a delay period, they'd be like, wait a minute, one of those was chair. You know, and they could then get all the words, or almost all of them. They're usually, 12 to 16 words. A person with Alzheimer's disease will have a rapid rate of initial forgetting. They will say, what words? Okay, what words? Absolutely no encoding of information. So it's a huge difference. Also in normal aging, there's going to be the word finding difficulty that I mentioned, a slightly shorter attention span. That's normal aging. This all begins, starting around 50, 55. There may be decreased ability to perform complex tasks, slightly decreased. Normal aging shows no difference in vocabulary knowledge, general knowledge, things that you have learned over time, because it's all retained. Reading comprehension, all of those stay normal. That's very different in Alzheimer's disease or dementia. There are about 50 known causes of dementia. Alzheimer's disease is by far the most prevalent. Makes up about 60 to 80% of all dementias. The more common dementias are Alzheimer's disease, followed by vascular dementia, Parkinson's disease, Lewy body dementia, and frontotemporal dementia. But there are many, many different causes. The prevalence increases with age. About 2 to 4% of individuals ages 65 to 74 may have a dementia, whereas between ages 75 and 84, it may be as much as 15%. And then beyond the age of 85, it increases to anywhere between 40 and 50% of that age group. In Alzheimer's disease, the pattern is very slow and insidious. So at first, you're not quite sure what's going on with the individual. In vascular dementia, the pattern is more of a stair step, because vascular dementia makes up, say, strokes, multi-infarct dementia, the tiny strokes that are in the deep white matter in the brain. And okay, that's it. I'll stop here. Any questions about that?
I would just add that part of the workup is to rule out things that can be reversed. For years, there's been a rubric of pseudodementia. And if someone has low thyroid, some other hormones that are out, chemistry has an infection, those kinds of things, it can mimic those symptoms that she has said. So one of the starting points in where a general practitioner can start is, let's check your thyroid, let's check your white count, let's make sure you're not anemic.
This is actually really good. I call it with corpse explosion. You're thinking it's something for food.
And oh, okay. And
Okay.
the other thing is that the normal aging doesn't present racial that Ruth suggested. There's some overlap, but they are distinctly different.
Hi, I'm Carol Janicki. I'm going to take a slightly different tack a little bit because several of the questions we got from various folks overlap. So Ruth talked about the difference between normal aging and dementia. And one of the other questions is the difference between depression and dementia. And obviously there's some overlap. So I want to do two things because I don't know everyone. I know some of you better than others. First question is, the title of this presentation is The Journey. And could you just give us some feedback by show of hands where you all are in this journey? Are you kind of more at the beginning, trying to understand? Are you kind of in the middle where your loved one is beginning to really, as Dr. Edwards said, switch into the disease process more noticeably, or are you closer to the end? So who is kind of at the beginning? Just raise your hand and beginning. Who's more in the middle? And how about more at the end? Okay. And if you were here for Dr. Edwards, he referred to different stages, and I'll refer to them a little bit and try to also define them. I have another question. How many in this room have experienced feelings of depression? Just raise your hands, or if you're uncomfortable with it, don't, but just, right. How many of you have felt anxious at times? Okay, I'll include myself. How many of you have felt stressed?
Oh, yeah.
Okay. The point I want to make by asking those questions is that these three things are not abnormal. There are psychological way of signaling that there are things that we need to deal with. So it becomes important. I want to read you just quickly some simple definitions of those three states, and they become very relevant to what you as a caregiver experience and what your loved one is experiencing. They go for both people. As everyone in the room acknowledged, we've all experienced these things. So stress is more readily defined as when you face a difficult challenge, you may feel like you could handle it if only I had the time to do it. And then you begin to feel, if you don't have the time, overwhelmed. Well, maybe I won't get to do it. And then feelings of fear start to emerge. I'll disappoint somebody if I can't do it as well as I think I should do it. And then the tension and some of the more somatic symptoms of anxiety start to emerge, the tummy aches or a headache or fatigue. That's called feeling stressed. The difference between that and anxiety is that anxiety is more of a psychological state. You fear that something really bad or dangerous is about to happen, but you may not be able to identify specifically what that thing is. So you become anxious. What am I going to do about it? And you can start to connect the dots here with how it feels to have a loved one who may be starting to exhibit signs of one of the dementias that Ruth talked about. So it's a sense of danger that something is going to happen to you. And what happens to many people is they start going over and over and over and over. That's called worry. That's part of anxiety. And then, of course, if that continues, the fear of losing control of the whole situation becomes overwhelming, and people often experience, or sometimes experience, panic attacks, heart racing, their blood pressure, all of those physical concomitants of the anxiety. Depression is a little different, and that's why I wanted you to hear these differences in a kind of a simple way. Nothing simple about them, but it is possible to reduce it. Depression is actually called, and I found these great simple definitions. It's you feel that you experience life as hopeless. Why bother going on? There's a sadness that begins, and this could start early in childhood and then recur throughout the lifespan. And that you tend to often feel lethargic. Why bother? Withdraw socially. Some people sleep too much. Some people sleep with interrupted sleep cycles. People start to give up trying to cope. And there's a lot of, and they feel worthless. Like, why bother? Nobody's going to love me anyway. Now, again, I want you to think about Dr. Edwards' presentation and how some of these things tie in not only with your experience, but with what your loved one is experiencing. So those are the three things that I wanted to distinguish. What I'm going to do is pass out, and you can just look at it as people present. And you can pull these, I would have loved it if each of you could have filled these out, but that's the researcher in me. But it's not going to happen. These are clinical scales. You can pull them off the internet and use them to just see where you are. Because essentially what happens is the longer depression and anxiety, which is of course related to stress, continue, the more you may get to a place where you need to consult with somebody with help and how to get out of it. Now, I just wanted you to see, and if you look at these quickly, you can see which ones are anxiety, what the thinking is that looks like depression. I'm worthless. Nobody will love me. I can't do anything. It's out of control. So with that, I'll turn it back to our other panelists.
So I think the next thing we're going to discuss are the differences between depression and dementia. So there are numerous differences between depression, which is what Carol has just described, and the early stages of a dementia. In depression, depressed mood will be more predominant than any kind of cognitive slippage or confusion. In an early dementia, it will be the opposite, right? You'll have more confusion, cognitive slippage than you will necessarily. You might have some anxiety as well, because I mean, imagine if all of a sudden you're like, shoot, and it's beyond the why did I come into the kitchen kind of experience that we all have at our age of not under 50. So that can be when you have that kind of confusion, it can create some anxiety in the individual with an early or mild dementia. Depression is not a predominant feature in middle or late dementia. It's not predominant. It might be there, but it's not a predominant feature. In depression, there may be a waxing and waning of depression. In dementia, although there may be some waxing and waning throughout a day, typically in a dementia, you're going to have ongoing confusion, which could get worse as the day goes on because of fatigue. Whereas in depression, a depressed mood is going to be more predominant in the morning, right? And then as the day moves on, mood may increase and improve some. Now, daily functioning, there could be impairment in daily functioning in both conditions. So you may have an individual that hasn't showered. Well, have they not showered because they're too depressed to shower? Or have they not showered because they really can't get it together to do all the steps required to prepare to take a shower? And depression is treatable with medication and psychotherapy. So those were the main things I wanted to add. And then if you all have other things to add regarding the differences between depression and dementia.
Yeah, a dementia has losses in several domains, not just memory. Spatial orientation, or, getting lost, not recognizing things. Abstraction, how are arm and a leg similar? Language, it goes beyond just, oh, what's so-and-so's name? We can't even identify and erase something of the word that is common in practice. And deportment, and I'm not talking just a real, this person is not themselves, whereas they used to be mild, easygoing, use good language, kind. The person becomes belligerent, fighting, resistant, curse words, so, which doesn't happen necessarily in a depression. So there, and a lot of the symptoms do overlap, as she was talking about, the lethargy, the apathy, the just not wanting to do anything. But there are distinct differences.
Just a fast note, there are differences between men and women in the expression of depression. And that would be true also in terms of somebody with a dementia. So knowing, for example, men would more frequently present with somatic symptoms. My stomach has been bothering me, I can't sleep. Women may present with slightly different aspects of depression. So there are slight differences to be aware of. It's not all the same. Also, people, I would say, I'll use Parkinson's as an example, may have many of the Parkinsonian symptoms, but dementia may not be part of it. They may still be cognitively alert and able to express some of the feelings that we just talked about. So just wanted, it's idiopathic, just wanted to say, you know, be aware that size doesn't fit all, but generally, these are good parameters.
So the next thing we're going to cover, I'm going to cover diagnosis of Alzheimer's disease and Parkinson's disease and other dementias. Lucy will then cover the treatment, and Carol's then going to discuss protective, protective. So the first thing is you have a loved one, which sounds like many of you have experienced this already. You first take your loved one to your primary care provider, right? And they run the tests that Lucy was talking about, urinalysis, lots of blood work to see if there are metabolic issues going on. Urinary tract infection among older adults can create a delirium. So if a person has, say, a mild to moderate dementia and they get a UTI, their cognition is, you know, they're going to have a delirium. Their cognition is going to plummet very quickly. You treat the UTI and their cognition will improve slightly to whatever level it was before. So the PCP really starts with basic screening, inadequate screening. The next step then would be referral to neurology. Neurologists can do more in-depth evaluation, EEG, looking at brain pattern, brain waves. They could do CT, MRI to see if there is generalized cerebral atrophy, meaning a shrinking of the brain, versus areas of infarct, right? And that would then lead more to diagnosis of multi-infarct dementia. And then the next step is neuropsychological evaluation, which is what I've done until 3 months ago. So Lucy had mentioned language and visuospatial functioning. Well, neuropsychological evaluation looks at all cognitive domains. Learning and memory, principal one. Language is receptive language, understanding what's being said to you. Expressive language, being able to speak. Confrontation, naming is a huge one. In early Alzheimer's disease, you will see deficits in confrontation naming. So we have a test called the Boston Naming Test, and people are shown numerous pictures of, one at a time, of very commonplace objects. And you have to name them, not fast, but you name them within X number of seconds. And people with Alzheimer's disease will have difficulty doing that. They'll have more impaired performance than the standardized sample. We look at visuospatial functioning, we look at executive functioning, planning, problem solving, reasoning, judgment. All of these test performances are then compared with their same age group, gender, and level of education. And we get a pattern of performance across these tests that then lead to diagnosis. And it's very interesting because you can really, on testing, clearly see the difference between normal aging versus a dementia, even if it's early onset, and the type of dementia, along with the clinical exam and the patient's presentation, of course. In Parkinson's disease, the diagnosis of dementia, you have to have impaired cognition, but not necessarily at the onset. So someone could be diagnosed with Parkinson's disease and not have dementia, right? They've got more of the tremor, the mass facies, the bradykinesia, which is slow initiation of movement. If you say stand up, it might take them a second or two longer to initiate that movement. Bradiphrenia, slow thinking, it might take them a second or two to initiate response to a question. Dopamine is the main neurotransmitter involved in Parkinson's disease. There's a part of the brain that just stops producing as much dopamine, and that leads to the tremor, the mass facies, and all of the symptoms. There is a treatment called the DAT scan. Well, it's actually a diagnostic instrument, not a treatment. And it looks at the area of the brain, substantia nigra, that produces a dopamine. And it's very useful in diagnosis. Let's see, in Lewy body dementia, the primary features are Parkinsonism, which not Parkinson's disease, but Parkinsonism, the tremors, the slowed movement, masked faces, but it's not Parkinson's disease. You also have visual hallucinations and fluctuating cognition. Anyone in here have a loved one that's been diagnosed with Lewy body dementia? No, okay. How about frontotemporal dementia? Anyone in here? Okay.
A friend.
Okay, so the primary features in that are disinhibition, apathy, loss of empathy, perseverative or compulsive behaviors, hyperorality. They may eat too much. They may eat things not necessarily that are inedible, not like pica. Impaired language and executive ability. So it's really affecting the front part of the brain. Planning, problem solving, reasoning, judgment. Okay, I'll stop there.
Well, treatment of Alzheimer's is sort of the holy grail. It's what we would all want. And it is manageable. The symptoms are manageable. We have yet to get something that really, really stops the course of the disease. We have things that slow it down and can help the symptoms, but we don't have anything that will stop it in its tracks. So the medicines that we have turn back the hands of time. They can get somebody back to where they were a couple years earlier, but it doesn't cure anything. And you've all heard a lot of hype about the disease modifying drugs. These are those that supposedly can reverse the course of it. Well, not there for prime time yet. There are a few that there's proteins in the brain that are different from the proteins in Parkinson's. These are beta amyloid and tau as opposed to alpha-synuclein. So they're different protein structures. And they are just mess up the nerve cell. They put tangles in the nerve cell and outside so that the cell doesn't fire normally. The medicines that we have can stop the reuptake of one of the neurotransmitters that helps. Acetylcholine, she talked about dopamine. Acetylcholine is the one that works in Alzheimer's. And we can help make it more of it around so that the nerves can function better. And those are, they've been around for 15 years, and we don't really have a whole lot that's a lot better. They are the typical name for them, so you may have a loved one on them. They're cholinesterase inhibitors. Cholinesterase is an enzyme that breaks down acetylcholine. So if you stop that enzyme, you get more acetylcholine, more of the good stuff. And dinazepril or Aricept, Exelon or rizatriptan, and galantadine are the ones that are most commonly used. They have various ways that you can deliver the medicine. Main side effect is if you take them by mouth, they can make you really nauseated and cause you to gain to lose weight. Decrease your appetite. They can make you a little dizzy. The patches that Aricept is available in minimizes that because it doesn't have to go through the stomach. And they, as I said, can delay going from one stage to the other by a year, year and a half. And by that I mean somebody ending up in a nursing home as opposed to being able to help your loved one at home with the system. So they're not a cure-all, but they're what we've got right now. Namenda works on another neurotransmitter, and the combo can help behavior better than either one of them alone.
And I just wanted to throw in one quick thing. As Lucy was talking about these medications, cholinesterase inhibitors and so forth, the real key for the caregiver is how is this affecting ADLs, activities of daily living, or instrumental activities of daily living? Bathing, dressing, grooming, toileting, feeding, or activities of daily living. Instrumental activities of daily living are things like opening the mail, managing a checkbook, driving. Okay, so we're going to see those things will fall away sooner. But if an individual can still help with bathing, dressing, grooming, toileting, feeding, they can stay in the home longer. And that's what the cholinesterase inhibitors are trying to prevent the decline of that, slow that progression, so the person can be more manageable at home longer.
My loved one was put on dinazepril recently, and she had horrific nightmares after starting it. Is that a common thing?
That is.
Yes.
Nightmare. Yeah.
So if you have this diagnosis, it is certain that whether you are slowing it down or not, that it is going to progress over time.
It is, and if you stop it, the person, and that's another big thing, is when do you stop these medicines? When the person is not getting any more benefit from it. If the person has a side effect, there's one way you can approach it. You can switch from one of the medicines to another, or you can cut the dose down a little bit and see if some of those go away.
Oh,
Go ahead. I'll ask later.
if it's a medication question, go ahead.
Yeah, I was just gonna mention, there are a lot of medications out there that have side effects that can bring on delirium or worsen dementia symptoms. And I wondered, and I think a lot of those are prescribed by providers that either don't think about it or don't know about it. How can caregivers protect the person they're caring for from being on medications that are going to cause a problem?
I would say consult with the neurologist. Carry in the medicines, the bag of medicines, every time you go to a provider. Say, my loved one's on this. I notice that they're more confused since they started this medication to treat this condition, which is not dementia. let the neurologist take a look at what's being prescribed.
One of the first things they'll try to do is slowly come off of a medicine, because the polypharmacy or lots of medicines can do exactly what you're saying. And another resource, in addition to the neurologist, ask your pharmacist.
Yes.
They're experts in it, and they can cross-index everything that they're on in the computer.
A question that has come up for me in my clinical practice is why bother getting a diagnosis? You know the person is declining, you see well, the utility of that hopefully became clear. And this is especially important for family members to understand why you're going through these processes, because what Ruth has described takes time. It takes appointments. You've got to get the person there. So it has its own level of stress incorporated, but it is useful. It's also useful for communication between professionals to have that label, even if you may not find it helpful for yourself, but it is a useful thing, and that's a good thing to educate your support group with. Also, just one other point, slowing down some of these declines, the symptoms, really allows you as caretakers to have a little bit more time to deal with planning and what you want to do. So there's utility there also. And to just give yourself time, reduce the stress, taking care of yourself a little bit more. The other thing that we wanted to talk about briefly, another question that comes up, and it came up not quite this way in the questions that were submitted, is, am I at risk? What happens if I am at risk also? I'm the caretaker, but my family tree and my genetics include dementias. I think it's important, even though Lucy says there are no medications that cure, which is true, a lot of progress is being made research-wise on what are called protective factors. In other words, everyone who has the markers for either Alzheimer's or other neurodegenerative problems doesn't develop those disorders. And so there's longitudinal research that really looks at what are the risk factors that have people heading in the direction of Alzheimer's disease diagnosis, and those who have the markers, like the genetic markers, but don't ever develop it. And I'm going to just summarize briefly, and then I want to invite Cambria to talk, if you're okay with this, a little bit about her experience. Briefly, there's a wonderful longitudinal study, if you want the reference to it, ended in 2017. And the short summary, after you get through all the technical stuff, is that the things that help most for people who may be at risk, but who don't go on to develop the disease, are healthy lifestyle, exercise, you can name it, diet, managing cardiovascular risk at an earlier age, managing diabetes, high blood pressure. So all of these things are within your control if you worry about this as an issue. I want to turn it over to Cambria to